Dr. Vincent Rajkumar has not joined. We'll start still?
Yes, sir, we can start.
Okay. First of all, as we celebrate the 74th Republic Day of our country, I want to wish everybody a happy Republic Day and good evening to all the faculty and students who have joined from India. Though I think our international faculty from US have not joined, but still a very good morning for him. This Journal Club of Image is getting popular day by day. Faculty as well as students are getting interested to know the in-depth about a publication. Today we have presentation from NIMS Hyderabad. The journal will be presented by Dr. Stalin and will be discussed by the faculty from NIMS Hyderabad, Dr. Sadasivudu. Our international expert will be Professor Vincent Rajkumar from Mayo Clinic, Rochester. All of those people, they don't require any introduction. We all know them very well. Today's article is very interesting. This is the revision of international staging system for overall survival in multiple myeloma. This is a European Myeloma Network report from the Harmony project, which was published in JCO October 2022. I am also yet to read this article. So we will be listening to Dr. Stalin. Dr. Stalin, please start your presentation.
Is my screen visible?
Yes, Dr. Stalin.
Yes, sir. Just put it full screen.
Yeah, it is full screen.
Full screen.
Yes, good to go, sir.
Yeah, I'm clearly audible.
Yes, you are audible, Dr. Stalin.
Okay, so good evening, everyone. Thank you, Dr. Pankaj sir, Dr. Uday sir, and the Image for giving me this opportunity to present the Journal Club through the Image platform. So over the next 15 to 20 minutes, I will be taking you to the publication of the second revision of the international staging system that is called as R2ISS for overall survival in multiple myeloma. This is an European myeloma network report within the Harmony project. We all know that multiple myeloma is a hematologic disease with heterogeneous outcomes, and these outcomes are highly variable. Their range can from less than 6 months to several years, and with a median time of approximately 3 to 4 years. This variability derives from the heterogeneity both in the form of myeloma cell biology and also the myeloma multiple host factors. This is the first staging system which was proposed by Salman and Dury in 1975. They used certain criteria to group the multiple myeloma into 3 stages, which are the factors which are highly prognostic in multiple myeloma, like hemoglobin value, calcium, and the number of lytic lesions on a X-ray, and also the M component, what is the amount of the M component. Based upon this, they have grouped the patient into 3 stages, and they have showed that the stage significantly predicts the survival in multiple myeloma patients. This is the first staging system which was proposed in multiple myeloma way back in 1975. So later, a international staging system was proposed and which was published in 2005 in the JCO, which taken into account the 2 factors, the beta-2 microglobulin and albumin. What is the need of this staging system? Although when Salman Dury's staging system was there, is the amount of lytic lesions what we observe in a conventional radiographs is highly variable. That is interdependent. That is depend upon the radiologist who is looking and reading the X-rays. So to negate that, so they have taken a 2 significant parameters which has impacting outcomes, and they have proposed a staging system based upon the beta-2 microglobulin value and the albumin value. And among the 3 stages, these 3 stages significantly predicted the overall and progression-free survival in multiple myeloma. So irrespective of the region and irrespective of the age, the ISS stage significantly predicted the overall survival. So later, So we moved into the knowing the molecular biology of the multiple myeloma cells, and we had recently discovered that the multiple myeloma is driven by certain genetic factors, and they have significant prognostic impact on the outcomes of the patients. So the ISS has also been outdated, and the revised international staging system, which is incorporating along with the ISS staging system the cytogenetic abnormality which is determined by interface FISH and also the LDH. So all these parameters were clubbed, and they had proposed a revised international staging system which was published in 2015 in the JCO. And this had shown that irrespective of whatever the regimen the patient has taken, whatever the treatment, either transplant or non-transplant based treatment, the revised international staging system has significantly predicted the overall survival and progression-free survival in multiple myeloma patients, and it is irrespective of the age too. Even in less than 65 years or more than 65 years, the RISS staging system has significantly predicted the survival. But there are some limitations to this RISS because majority of the patients, so more than half of the patients are subgrouped into the RISS stage 2, including these patients has a different risk levels of progression and death. And recently we all know that 1Q has also shown to be a highly prognostic factor which was not included in the RISS staging system. Apart from these two factors, so we all know that the recent concept in multiple myeloma like the double hit and triple hit, and the additive nature of each of these factors was not added into the RISS staging system. So these are the various limitations. To address these limitations, a revised international staging system was proposed. So this is the second revision, which is under the European Union funded Harmony project. In this work, the prognostic value of each single baseline feature in an additive fashion was designed, including the 1Q amplification. So what are the how many patients? Almost 10,843 patients which were enrolled into 16 international multi-center clinical trials from 2015 to 16 and who have met the data quality requirements were taken into this project, and these are the various trials from which the patient data has been taken. And during their upfront treatment, all patients received either a PI or an IMID or both during induction, consolidation and maintenance phases. What was the primary endpoint? The OS was the primary endpoint and progression-free survival was the secondary endpoint. The bone marrow plasma cells were enriched using a CD138 directed enrichment, and these were analyzed by FISH as described in the training set or by a molecular methods validated against the FISH. What are the various cytogenetic abnormalities detected in this? They are deletion 17p, gain or amplification of 1Q, T414 and 1416. Since but the data on 1Q was not available in all patients, and whatever the available data is present from them was taken for the validation of the 1Q. And patients were considered positive for each cytogenetic abnormality when its percentage was higher than the cutoff threshold defined by each local laboratory. So the patients are grouped into two sets. One is the training set and the validation set. The training set consists of approximately 7,000 patients and the validation set consists of the 3,700 patients. And these validation set patients are treated in the UK NCRA myeloma 11 trial. And these patients were the enrolled which into the UK NCRA trial are both transplant eligible and ineligible. And the features with the highest impact on the overall survival and progression-free survival were further evaluated to build an additive score. So this is a statistical analysis. A score value was calculated and assigned to each predictor and was computed as the ratio between the coefficient of the Cox model using OS as an outcome. And the coefficient is related to the international stage 2 and stage 1. And this coefficient is between stage 2 and stage 1 was used as the reference value, and the score was given as 1. And the scores value assigned to the predictors were calculated and they are rounded to the near of 0.5. So a total of 10,843 patients, among them 7,000 in the training set and the 3,700 in the validation set. Majority of the patients in the training set are less than 65 and transplant eligible. And in the transplant ineligible, half of the patients are less than 65 and transplant eligible, and half of the patients are transplant ineligible. The median follow-up in the patients in the training set was 75.5 months, and in the validation set, it was 60 months. And 40% of the patients received an IMID treatment, 15% PI, and 46% of the patients in the training set received both IMID and a proteasome inhibitor. So these are the baseline characteristics and the treatment received, but the gain of 1Q data is available only in 60% of the patients. So the PFS and OS impact of the single variables, these are the various variables which was almost which had shown highly significant among the all variables, the ISS staging system, the deletion 17p, LDH, 414, 1Q, 1416, performance status, heavy chain, creatinine clearance. Of these, the factors which has shown to have significant impact on the overall survival are the ISS staging system, the deletion 17p, LDH value, and the T414, 1Q, 1416, and the performance status and the heavy chain and creatinine clearance has not shown much difficult, and they are not taken into the scoring system. And among the cytogenetic abnormals, 1416 has not shown to have much difference in the progression-free survival, but it had shown an overall survival impact. So this is the score definition on the basis of the evaluable patients and the how score is calculated. And the ISS stage 2 is given a score of 1, ISS stage 3 is 1.5, deletion 17p is 1, LDH high is given as 1, and T414 is given as 1 point, and 1Q gain is given as 0.5. Based upon this, an additive score value is given. So the low risk consists of 0 score, low intermediate is 0.5 to 1, and intermediate high is 1.5 to 2.5, and the high score is 3 to 5 points. So these are the grouping of the patients. So the patients are grouped into 4 stages compared to the RISS stage, where the patients are grouped into only 3 stages. So R2ISS has 4 stages, and majority of the patients in both group, both training and validation sets, belong to the stage 3. So this is the OS and PFS in the training set. The median overall survival is not reached in R2ISS stage 1, whereas it is 109 months, 68, 38 in stage 2, 3, and 4 respectively, which was highly statistically significant. So in the training set, the R2ISS staging has significantly predicted the overall survival. Even in the validation set, the R2ISS staging has significantly predicted the overall survival. It is not reached in stage 1, 89, 56, and 34 months in the stage 2, 3, and 4. This is the OS in transplant eligible and ineligible. In both subgroups of transplant eligible and ineligible, overall survival is significantly predicted by the R2ISS staging. And this is according to the treatment regimen, whether it is an IMID, PI, or both IMIDs and PI. So whatever the patient received the treatment, the overall survival is significantly predicted by the R2ISS staging. So this is the comparison between the R2ISS and RISS. So we all know that the majority, according to the RISS, majority of the patients will be grouped into R2ISS, RISS2, and the patients in the RISS2 were subgrouped into the R2ISS as approximately 517 patients into the R2ISS low intermediate and 811 patients into intermediate high, and R2ISS high group 44. So from this, we know that RISS stage 2 is a highly heterogeneous group of population with varied survivals, and this shows that a newer prognostic system like R2ISS, which delineating the population of RISS is needed. So this is the comparison between the RISS and R2ISS. See the dotted pink line, this is the RISS stage 2. So when these curves are superimposed on the R2ISS staging, so this clearly shows that there are a subset of patients in the RISS staging system, RISS stage 2 patients, who have a survival almost nearing the stage 1, and certain subset of patients who had a survival almost nearing the stage 3. So this says that a newer prognostic system, which is incorporating into all patients various factors, need to be taken into account. So, and R2ISS should be the further way to go compared to the RISS. So in this study, so widely available prognostic tools such as ISS, LDH levels, and cytogenetic abnormalities identified by FISH were combined to define additive scores to stratify levels in patients with newly diagnosed multiple myeloma. Compared with RISS, this R2ISS adds 1Q to the score, and its calculation takes into account the prognostic significance of coexistence of several cytogenetic abnormalities. And of note, 1Q gain is a very common finding in newly diagnosed multiple myeloma patients, with approximately 40% of patients presents with this abnormality. And this variable was missing in many old literature, including the in analysis, and the multivariate analysis on the available patients clearly confirmed its prognostic in patients with newly diagnosed multiple myeloma. In this analysis, 1416, which was included in the RISS, was significant in terms of OS, but not PFS, and as a consequence, which was not included in the R2ISS calculation. Indeed, despite its biological importance, 1416 is rare and usually presents together with other adverse prognostic factors, and it may not be a marker of high-risk disease per se observed here and by other groups analyzing large cohort of patients. Therefore, 1416 was not included into the analysis. What are the advantages? It is validated in an independent cohort of patients with longer follow-up compared to RISS. In the RISS, the follow-up was only 46 months, whereas in R2ISS, it is 75.5 months. And the additive nature of score calculation allowed to identify the 4 well-separated group of patients rather than the 3 RISS categories. And when we observe the R2ISS population, in the R2ISS, when you combine 1 and 2, they accounted for 50% of patients, and 3 and 4 accounted for 50% of patients. So this is important because within the RISS, the low or high risk populations are usually too small. So when you are doing a trial, and the comparison of the survival between is a problematic. So in the future trials, if R2ISS was adopted, the newly diagnosed multiple myeloma patients can be split exactly into the half. So into the 1 and 2 group and the 3 and group and the subgroup analysis, and potentially designed risk adapted approaches in a substantial number of patients can be done. So what are its limitations? Even though this has robustly analyzed with a very large number of patients, there are certain limitations because a limitation of the study is that transplant eligible patients, especially in the training set, are more represented compared to the non-transplant eligible patients. And in non-transplant eligible patients, especially apart from the disease-specific biomarkers, a patient-specific biomarkers like the frailty of the patient's comorbidities and the tolerability to the chemo, these are all also important, which can significantly predict the overall survival. These are not explored in this R2ISS2. And the need for a long-term follow-up to develop a prognostic model affecting the overall survival precluded them from validating the R2ISS in patients treated with newer combination of drugs like KRD, KCD, DARA, and the quadruplet combinations like DARA-VRD and DARA-VCD. So, however, the validation of this R2ISS in this population of the newer therapies will be pursued as soon as the follow-up is mature enough. And this score was entirely developed and validated in a population of newly diagnosed multiple myeloma enrolled in the clinical trials. And this R2ISS need to be validated in the real world population, that and the applicability of it into the clinical practice also to be tested. But we all know that these ISS, LDH values and the cytogenetic abnormalities has become a part and parcel of the multiple myeloma diagnosis and treatment. And even in the validation in the real life scenario, it may not be a much problem. As shown in the validation set, if molecular biology techniques are validated against FISH are available, they can be used to calculate the R2ISS as well in the real world scenario. Compared with the RISS, the new system has the advantage of being a flexible additive score, and that can be easily updated with a new prognostic factors as they emerge in the multiple myeloma field. So this, as it gives additive score, if at all a new prognostic feature comes into the myeloma field, so that it can be added and a new additive score can be built up. But various other factors like the circulating plasma cells, we know that they have a significant impact on the overall survival of multiple myeloma patients, and the TP53 mutations, 1p30q deletion, and the lambda chain translocations, and the presence of an extramedullary disease, they are independently associated with the dismal outcome, and they may potentially be included once the data is large and the prognostic significance seems robust, and they can be potentially included in the future risk stratification strategies also. Additionally, the discrimination among 1q plus cases of gain or versus amplification may further improve the risk stratification. And also the data on the next generation sequencing and the gene expression profiling with a potential prognostic impact were not taken into account in this risk calculation. A long-term follow-up and an analysis of these prognostic factors uniformly evaluated in a large cohort of patients are needed to conceivably improve the current prognostic score. Moreover, we all should understand that whether the interaction among these risk factors could not be merely additive, but they can also be synergistic in predicting the poor prognosis. In addition to all this, we all know that MRD assessment and the MRD had shown to have a significant impact on the overall survival and also the outcomes in multiple myeloma. And the combination of this current R2ISS staging along with the response evaluated during the treatment by sensitive techniques like minimal residual disease inside and outside bone marrow, it also should be explored in the future. And the achievement of MRD negativity assessed at high sensitivity demonstrated to overcome the poor prognosis confirmed with the baseline prognostic risk factors. So by combining both these R2ISS and MRD, the design of risk adapted versus an MRD adapted strategies can be pursued in a substantial number of patients with newly diagnosed multiple myeloma patients. So as it was done for the RISS, the value of this R2ISS score in a population of patients treated with relapsed refractory myeloma should also be explored. This is the present publication is only in the newly diagnosed multiple myeloma patients. So in a relapsed refractory setting also should be pursued. So to conclude, this new revision of the international staging system, that is R2ISS staging system, is a new simple prognostic algorithm. Compared with RISS, it showed an improved discriminating capability, especially in the large group of patients with intermediate risk, newly diagnosed multiple myeloma patients. And this includes simple and widely used prognostic markers, and the additive nature of its calculation easily allows the future inclusion of new prognostic variables. Thank you.
Thank you, Dr. Stalin, for the excellent presentation of the article. I think Dr. Vincent Rajkumar has joined. Good morning, sir, and welcome. And next, I'll request Dr. Sadasivudu to discuss the article.
Good morning.
Sir, good morning.
Sir, good morning, sir. Yeah.
Good morning. Yeah.
I think he discussed this article in detail. As we know, I think before 2005, the Salman-Dewey system was there to stage the multiple myeloma. It was very difficult to remember during our residency. We used to struggle to remember that one. Later, the very simple international staging system came into the picture, just based on albumin and beta-2 microglobulin. Later again, revised ISS staging system may come into the picture with LDH and the cytogenetics. Now, I think a little bit this one is having the more prognostic significance with easily doable this staging system, and we can prognosticate the patient very easily, and we can tailor the treatment based on this. Thank you for Dr. Stalin for presenting this wonderful article. Vincent, is there any comments on this, sir?
Hi. Did you want me to talk now?
Any comments on this, sir?
Okay. Can you hear me well?
Yes, sir.
Okay. So thanks, Dr. Stalin. Great presentation. And of course, you have read this paper really closely, much more than I had done. So I'll just give you some brief thoughts on this paper, as well as how to approach papers like this, which come out when you're talking about prognostic factors. So in general, even if you step back when in any kind of journal club, there are two ways of looking at a paper. One is just the really a deep dive, looking at how did they do the study and what were the pros and cons of the study. Could they have done it better? Is it really internally valid? Is it externally generalizable? All of that stuff is there. And we've gone through all of that very nicely with Dr. Stalin's presentation. The other way to look at these papers, and that's what's really important, and I think one that when you do journal clubs, you have to keep coming back to, just like the last time I talked to you about why a trial is done. It's like simply, why was this study done? What is the whole purpose of having another prognostic system? Like, is it simply to tell patients that we thought with the RISS your survival will be 2.5 years, but with the RISS-2, I think it's going to be 2.8 years or 2.9 years, or with the old ISS, it would have been 3.4 years, and I'm fine-tuning. I mean, like, really, does it matter to the patient whether it's going to be 2.5 years or 3 years or 3.5 years? Or even if that's accurate, do the numbers really translate, like what they found in Europe in a trial? Could you even tell a patient, say in India or in the US, that the median survival of patients like you with RISS stage 2 intermediate is XYZ? Is that number even reliable? Because there are so many other factors. So the whole question has to come up into, why are we doing these prognostic factor studies? The second thing is that prognostic factor studies, even if they are done well, and like in this study, very large sample size, and there's still some huge problems when you look at how the variables are put together. So for example, if you step back into the Dury-Salmon staging system, that system was developed as a staging system, which is similar to what they use in solid tumors, which is purely a measure of how much tumor there is. So it doesn't look at aggressiveness of the tumor, biology of the tumor, performance status of the patient. It's simply a staging system. Just like in solid tumors, you have stage 1 means very little tumor all in one place, and stage 2, a little bit more, stage 3, more. I mean, it's clear estimation of tumor burden. And the whole idea is that the more tumor you have, the more likely the less good your prognosis is going to be. The more tumor, the more spread it is. And so the original staging system that Dury-Salmon put forward is like a true staging system with a tumor burden estimation. So stage 3 has more tumor than stage 1. Here you cannot say whether stage RISS 1 or 3 has more tumor, because they're mixing biologic variables which are related to patient performance status, like albumin and all of that, beta 2, everything comes in. The importance for that is that it becomes more of a prognostic index, and the primary purpose then that this one will solve is not telling you how long your patient will live, because that is going to vary based on your patient and based on the country and what's available. It won't tell you precise, it'll give you more precision, but that's not really applicable or necessary in clinical practice. What it will help with is when we do other clinical trials, it will compare one trial versus the other more homogeneously, more accurately. So if I do a Maya trial and a SWOG trial, and I want to compare the two, and if I know that the Maya trial had X number of people with RISS 2, stage 1, stage 2, stage 3, stage 4, you can compare across groups to get a better estimation of how one trial population compared to the other, better than, say, the ISS or the RISS would do. So in that sense, this is very useful. But in the sense of telling your patient how long they live, it's not going to be the accurate one. Neither will another future one be. Secondly, it's not even necessary, because your patients are not looking for that fine of a number. And thirdly, you cannot use this to overcome high risk, because if I want to make patient survival longer, the way you make a patient with deletion 17 live longer is going to be different than the way you make a frail patient live longer, or a poor performance status live longer, or a low albumin live longer, or a patient with renal failure live longer. The way you overcome 414 might be different than the way you overcome deletion 17p or 1q gain. So for planning treatments and overcoming high risk, it's better to look at just a very specific biologic problem, like patients with deletion 17p and myeloma, and how do I overcome the high risk that the deletion 17p causes. And so keep that also in mind. One other problem which was touched upon by Dr. Stalin was the repeated use of clinical trial data sets to develop staging systems. The problem is that clinical trial data sets will give you wrong information, because, for example, you cannot get into a clinical trial if your performance status 3 or 4. So no wonder they don't find a benefit with performance status, and they threw that out, because they have all their patients are 0 or 1 or maybe 2. They usually exclude patients with renal failure, because if you have renal failure, it's hard to get into a transplant trial. So what happens then is that variables like 1416, which cause poor prognosis because they have a higher tendency to cause acute renal failure at presentation, will be omitted, because all the 1416s in your trial have good renal function. And the way 1416 causes aggressive outcomes is because it is higher correlation with renal failure. So those kind of problems happen. And then finally, I would tell you that you mentioned that there are some more variables that can be added: circulating plasma cells, extramedullary disease, frailty, etc. when you do multivariate analysis, like in this large 10,000 patient data set, I could take the same data set and come out with another RISS-3, which has completely different variables and will show similar separation of the curves. So a lot of times thought has to go with not only an unstructured, let's just look at all the variables, which one's predictive best, and then put together a model, versus let's look at what variables make sense. And I'm going to include those variables. And so more of a supervised way of picking the variables that you think matter, with some information on what does each variable mean, would give you a model that potentially has variables that are not overlapping with each other, that are not correlating with each other. So having all of these points together, my summary is that this is one other prognostic index, not truly a staging system. It doesn't estimate tumor burden. It estimates risk, prognostic risk in clinical trial populations. The main use of this will be when we compare clinical trials, one trial versus the other in a non-randomized fashion, so that you make sure that the trials are indeed comparable, or you compare only the subsets. But it won't be really useful in counseling your patient or in terms of giving a very clear number, because the numbers won't be reliable or applicable, and it won't be useful in overcoming high risk. If you just say, I'll take the highest RISS-2 and I'll do a trial for them, that is not going to work, because they'll have a hodgepodge of patients with many different reasons who are put together, and that's no way to overcome high risk.
Yeah, thank you very much, sir, for wonderful analysis. I think, as I said, all these patients under clinical trial, I think, as I said, they're selectively included into the clinical trial by exclusion of so many other criteria. Definitely, sir, that we can't generalize the thing. At the same time, trial also the drug treatments also what they have given also different from different trials. So I think we can't group together to define these outcomes, and nice explanation, sir. Thank you very much, sir. Any other faculties, sir?
Yeah,
Ranjan,
I think Dr. Uday wants to give his
yes,
comment.
Sir, I have a small query to Dr. Vincent. Sir, you have explained well that how these staging systems or prognostication systems come into place and how we utilize them, or what is the current utility of this. But over a period of time, what actually happens is most of the drug companies or the pharma industry, they come out with the fact that the patients go, a certain group of patients go into high risk. Therefore, we have to follow aggressive approaches. And in the next 2 to 3 years to come, people then start misreading these prognostic scorings for trying to push more aggressive therapies, monoclonals into the market, and other things. So how could we prevent that? So is there a way wherein we can actually put across the points that you have enumerated for the students or for the people who read or who understand these prognostic systems better?
Yeah, I think the main thing, as I mentioned, is to immediately, when you take a paper like this and read it, you just have to remember that this applies when somebody wants to compare a Maya trial with a SWOG trial, and they want to compare the outcomes. They look at the proportions of patients and see, oh, the Maya trial enrolled patients who are predominantly RISS-2 stage 1 versus the SWOG trial had more in this. Or you could compare only the two groups of patients, like the lowest risk group in both, and see how well they did. And if the inclusion and exclusion criteria are similar, you may be able to make some cross-trial comparisons and say, the really low risk RISS-2 patients did better on DERA-RD than VRD, or something like that. But to keep in mind that these systems cannot be used for overcoming poor prognosis or pushing treatment, like you said, because the way you overcome a high-risk biology is different. And that's why, if you look, the last time when I came there in Bangalore, or was it there, that somebody commented that for bortezomib maintenance, it was more efficacious with the deletion 17p and not so much with 414. Remember that? And that's true, because you cannot expect a new treatment to overcome all the high risk due to low albumin, high risk due to renal failure, high risk due to 14-16, high LDH. Each one's got a different reason why they are causing somebody to die sooner. And you have to have a different approach to overcome that. And what happens is people take the shortcuts and say, okay, we'll do a trial in certain groups. I would rather pool, because it's hard to do a trial only for deletion 17p, I would rather pool things that are probably going together. Like if I think that high LDH, circulating plasma cells, deletion 17p, extramedullary disease at presentation, they all are, for some reason, the biology is wrong. So that even if it's a young patient with good prognosis and good low tumor burden, they're still not going to do well because these are biologically aggressive. They're hard to kill, these cells. Then you can create one trial with this basket. But the moment you make it RASS2 high risk group will be included, then you've mixed 5 or 6 variables, which should not be mixed with each other.
Another small query. Now, when creating or suggesting prognostic scoring systems, so rather than having a investigator bias in trying to identify the most logical variables and trying to simplify it, or I would say oversimplify it by giving round numbers, like in R2ISS, they gave a scoring of 1, 1.5 and 0.5 to the various things. Shouldn't it be more statistically oriented, wherein we take a real world data and try to do a regression analysis for all the factors which are possible, which sound logical, and then try to give them a weightage accordingly. So for example, a Cockcroft-Gault versus the MDRD formula. So the MDRD has got all those power 2 of 0.728 and all those things, but they have got those numbers based on statistical reasoning, rather than trying to oversimplify based on only 3 or 4 of the information sets, subsets, which we have the most or which we fool the most, and trying to give them a round numbers or a whole numbers to oversimplify the thing. Won't it be a wrong thing statistically to prognosticate patients by this system of prognostication rather than a statistical system?
So it depends on what you're trying to accomplish. And that's where what people have done is taken things from population sciences, and when you have large data sets, start doing these kind of things without understanding the whole thing boils down to the very first question. What are you trying to accomplish? Okay. So for example, if I want to, if my goal is to be able to predict the height of a person using 5-10 variables, then I will do what you just said, because I will use the various variables statistically, which are the best at predicting so-and-so will be height XYZ, or the weight. So in certain kinds of studies that people do in the world, they really want to find out how much food is consumed by one human being, this based on their variables. Then this will work. If your goal is simply because that I have this large data set, I want to find the best way to split the 7 curves, your method will work the best. But if that's not your goal, if your goal is different, then you have to do a more supervised thing. So for example, if you say prognosis in a human being with cancer is affected by the host characteristics, the tumor burden, the biologic aggressiveness, and response to therapy, then you might a priori think, I'm going to pick one of the best variables for host, one of the best variables for tumor burden, one of the best variables for biologic aggressiveness, or 2 or 3, and then one for response to therapy, and put them together because they're non-overlapping. And again, they will give me the best estimate for the whole person. And even if the actual number doesn't work, the hazard ratios will work for anybody. So that's a more supervised way of doing it. If you already know, for example, if I get this 10,000 data set, I could come up with the hemoglobin, the platelet count, the AST, all of which won't make any sense to us, give the best outcome over deletion 17p or anything. But what do you do with that information? Because the patient doesn't need to know I'm likely to live 1.7 versus 1.8 years in that kind of precision. What you're trying to do is, with this information, number one, can I give a patient a general idea of are they going to do better or worse, for which you don't need this fine tuning. Secondly, I want to see which patient I want to give more aggressive therapy to, so that even though they're starting out with poor risk, I'll make them live longer. So then you need to know which are the variables that are really influencing aggressiveness, all things being equal from a host or a tumor burden standpoint. So it requires a lot of thought. And even in the emergency rooms, people have looked at it. Like, for example, if you know that echocardiogram of the heart tells you the patient who's having an MI better than chest pain or a history, it doesn't help, because the chest pain and history is known already before you do the echo. So the one information is already available to you. So the sequence in which you get your information also can be taken into account when developing parameters. Like, one might be very, very good, but it's usually obtained later in the time when the patient is evaluated. And so it really doesn't help with triaging the immediate patient. So the purpose for why you need a new prognostic system has to be so clear in your mind to know which, when you're doing an actual study, to know how am I going to construct my variables.
Understood, sir. Very nicely explained. So I think Dr. Tapan has got a query.
Authors want this staging to be widely used. Who will pick up first? Pharma industry for clinical trials? Tapan sir posted this question, sir.
Tapan sir is there. Sir can directly discuss
Yeah,
this.
you can ask also, sir.
Vincent can answer.
Yes, sir.
So, the other things is there is also all kinds of politics going on in any large groups like this. Not quite politics, but the international staging system and the revised international staging system, the ISS and the RISS, were developed by the International Myeloma Working Group, mainly because people were not able to compare trials one versus the other with the Dury-Salmon staging system, because the Dury-Salmon staging system had one very subjective variable, which is extent of bone disease, which each doctor might say, my patient has a lot more bone disease, and they artificially could inflate the number of stage 3 patients that they have with Dury-Salmon. So the idea of the ISS was to really, if I am going to compare across trials, I need hard variables that people cannot fudge. So the albumin level, the beta-2 level came into being. And then the RISS2 came separately. The RISS2, on the other hand, is not an IMWG project. It was just a group of people decided that they will develop a new staging system and call it RISS2. Like, if all of you want to get together and put forward another staging system and call it RISS3, nobody's stopping you. So people are just putting their names and calling it something. How well these things are adopted depends on how well the clinical trial community thinks that it really separates patients into groups that you can then use to compare one trial versus the other. But yeah, this is not an IMWG project, just so you know, that this is a European group that decided that they will call it RISS2, but it's not a full-scale IMWG project.
Any further questions? Any further questions?
I had one. There was something like, should there be a dynamic prognostic system as we do in myeloproliferative neoplasms like myelofibrosis? As Vincent has been telling, cardiac problem might come in, albumin might go down, performance status may go down. So we might have to bring in many variables as we go on treating a given patient.
Absolutely. And so variables change over the course of a time of a patient. And so really, I think, goes back to why do you need a prognostic system? If you are wanting a prognostic system so that you can counsel your patients better on what to expect in life, then all of these variables should be carefully assessed, not only initially, but throughout the history, so you can continue to tell them how well they're going to do. They may start with high risk, but if they become MRD negative, you might tell them, hey, I thought you might do well, but you might do XYZ, but I think you might do even better now because you've become MRD negative. So you can, for purely for counseling patients, which is so important. I think a good knowledge of these prognostic variables is so important. I usually look at these prognostic variables not in terms of the groups, precisely, are they RISS 2 or 3 or 1, but really try to understand how good is albumin, how good is deletion 17p, and then be able to give an estimate. Nowadays, for example, what I tell young transplant eligible patients who are going through a transplant is that based on real world data, that you will have a median survival in the US of about 13 years if you don't have any high risk biologic factors, and 8 years if you do have high risk biologic factors. So I'm not giving them a very fine tune. I do explain what the median survival looks like. And then as they do on their clinical course, if the patient with standard risk next bone marrow biopsy gets a high risk del 17p, you'll have to readjust what you tell them in terms of what to expect. So for that purpose, it is definitely useful. For comparing trials one versus the other, usually they look only at the baseline because that's all that's available to them. And that will tell you whether the same types of patients were enrolled in both trials.
There is one more thing, is any prognosis scoring system is usually we'll use it for two purposes. What you have mentioned, one is to prognosticate the patient, and the second one is to tailor the therapy.
Correct.
Is it so with this system, is it useful for us to just tailor therapy based on
No, it's not.
high risk? Not. Yes.
No, because it's mixing multiple variables,
Yes,
which are not, you cannot overcome them with a single strategy. So that's why the MSMART, we have the risk stratification driven mainly by the cytogenetics, because what we are saying is for people who have got good performance status, reasonable tumor burden, those people who have deletion 17p, 1416, 1420, 414, they for some reason have a biologic higher risk. It's hard to maintain a response in those patients. And therefore, we must do something beyond what we are doing. Right now, we are pooling even these four together. In the future, I hope we'll be able to say the way to overcome deletion 17p is XYZ. Sorry, the way to overcome 414 is XYZ, the way to overcome 1416 is XYZ, and really fine tune, just like they do for AML, based on the specific factor, you adjust the treatment accordingly, rather than pool all these three together and think that we can overcome all of that with one unified strategy. So when it's so complicated, even when you take these aggressive variables, you cannot mix variables that are predictive of high tumor burden or predictive of poor host factors like albumin, and then mix it together, or renal failure, which beta-2 microglobulin is affected by renal function. So if you mix them together, then you will come up with a heterogeneous group of high risk, and you cannot overcome them with the unified strategy.
Thank you very much, sir. Thank you very much for the brilliant explaining the trial. And thank you, Dr. Sadasivudu, for bringing out all those integrity of these cases. Now I hand over to Dr. Uday for the Eagle Eye competition. Uday, please.
Thank you, sir. I'll quickly share my slides. So just for the people who are naive or new to the Eagle Eye competition, so this is for the best commentary for the Journal Club, scan. So we generally give a recently published article, which is selected by the international faculty. You people send a 175-word critical analysis, which is generally by the third Thursday. And anybody, JR, SR, or a faculty can actually participate from any specialty. It could be from clinical hematology to oncology to pathology to PhD scholars to anybody. And the best commentary is selected by the blinded reviewers, and they are presented. Whoever wins the particular Eagle Eye competition, they get a journal scan certificate, few credit hours from the image, and vouchers worth 5,000 rupees. So the purpose was to read the latest articles on plasma cell dyscrasia, to learn the art of critical appraisal, to refine the art of scanning articles and writing letters to editors, and to get an opportunity to present in front of the international audience. And also, more importantly, it happens to be an inter-institutional competition at the end of the day, because some institutes take it very seriously, do a practice round beforehand, and then come up with a specific institute-specific commentary. So this time, the first prize winner is Dr. Revant Bodu. He's a consultant in clinical hematology from Spurs Super Specialty Hospital in Bangalore. So can I request Neerav to kindly play the slides of Dr. Revant, please? Hello. Neerav? Can you hear me?
Uday, we can go to the next item otherwise.
Okay, sure. So I think I'll quickly start the quiz in that case. For the quiz, sir, I think we require their support for them to run the thing, because they have to score the people.
Okay.
Neerav, are you online? Do we have anybody from the organizing event management team? Tirth?
Yes, sir. Yes, sir.
Yep. So Neerav, can you run the slides of Dr. Revant, please, first?
Sure. I opened it. It is with me only.
Just play the slides.
Yeah.
Respected teachers and dear colleagues, a very good evening. So today we are going to discuss the journal published in November 2022 in Blood Cancer Journal. This paper is based on Optimal trial, which is a randomized multi-center phase 2 trial. The title is bortezomib, bendamustine and dexamethasone versus thalidomide, bendamustine and dexamethasone in myeloma patients presenting with renal failure. So coming to the introduction, renal impairment is a serious complication in patients with multiple myeloma. Up to 25% of the patients will have severe renal impairment at initial diagnosis, and about half of the patients will experience renal complications at some stage of their disease. In the last decade, the overall survival prospects have considerably improved for patients with myeloma, but it is not so in the case of patients with renal impairment, and the median overall survival is still only 2 to 3 years, even in the era of novel agents. So this brings us to a question that these patients need to be dealt differently. The answer is yes. The results of MERIT trial have already shown that patients who are alive and dialysis free at 100 days of therapy are those who had greater reductions in their serum free light chains. Outcomes correlate with the depth of response. Therefore, the authors of this study hypothesized that a significant reduction in SFLC during the first 2 cycles of therapy would lead to an observed renal response, and they also allow for early identification of poor responders who might be candidates for alternative therapy. So now comes the question, what regimen to be used? So bortezomib or thalidomide based regimens appear to be attractive options because both these drugs are not renally excreted and they are recommended by IMWG. However, it is based on retrospective cohort studies only. There is no head-to-head trial comparing bortezomib or thalidomide based approach in this cohort of patients. So the backbone of this therapy is formed by steroid and bendamustine. Bendamustine has a dual mechanism of action. It is an alkylator as well as an antimetabolite, thus provides an attractive therapeutic option for patients with renal impairment. Then coming to the study design, patients of more than 18 years of age and renal impairment defined as GFR less than 30 ml per minute and newly diagnosed myeloma are considered eligible. Of the 88 patients screened over a period of 5 years, only 31 patients could be randomized, 57 are screen failures. 16 patients randomized to arm A received bortezomib 1.3 mg per meter square. 15 patients randomized to arm B received thalidomide 100 mg once a day for 21 days along with bendamustine and dexamethasone. Then the primary outcomes measured in the study are SFLC response defined as more than 50% reduction after 2 cycles and renal response after 4 cycles. Secondary outcomes were renal response at 2 cycles, overall survival, hematological toxicity, quality of life, and SFLC response at various time points. So the patient characteristics are balanced across the treatment groups in the study in terms of stratification variables and also baseline characteristics, which is exactly expected from such a study. Then coming to primary endpoints, the primary endpoint of SFLC response after 2 cycles, VGPR was achieved by 13 patients out of 16 in the bortezomib based approach, whereas it was only 3 patients out of 13 in thalidomide based approach. Then coming to the renal response, 5 patients in bortezomib based approach achieved a significant renal response. However, 9 patients, 6 on bortezomib arm and 3 on thalidomide arm who were dialysis dependent at the start of therapy continued to be dialysis dependent at the end of 2 cycles. Then coming to secondary outcomes, hematological toxicity is almost equal in both the arms, and deaths, 9 deaths were reported, 7 on bortezomib and 2 on thalidomide, and there was significant improvement in anxiety and depression, but there were no statistically significant differences in any of the secondary outcomes. Then coming to strengths of the study, the title is very interesting and they have a valid research question because the patients with renal impairment needs to be dealt differently, and these patients are commonly encountered in routine clinical practice by every myeloma specialist. And the best part of the study is it can be emulated in any center, even in the low and middle income countries, because of easy availability of the drugs. And if the results of this study could be validated in a longer duration follow-up and a larger study, it could be a practice-changing update. Then coming to weaknesses of the study has only very small number of patients, only 31, and the duration of follow-up is very short, and whatever responses shown in the study have not translated into overall survival benefit, and even the renal responses were not shown in the long term. So to conclude, the goal of therapy in newly diagnosed myeloma patients with renal failure should be to induce a significant depth of response and to improve renal function and also to improve the quality of life. Bortezomib based approach, as shown in the study, has a better chance of inducing such a response compared to thalidomide based regimens. However, the deeper responses did not translate into improved renal response or overall survival benefit at the end of therapy. So the study is currently underpowered to define outcomes. So the future research should focus on bortezomib based induction therapy with larger numbers and long-term follow-up data. It helps not only to predict difference in renal outcomes, but also to validate IMWG renal response criteria as well. I would like to thank the organizers for this opportunity. Thank you very much.
Thank you, Dr. Revant. That was a brief, concise general scan about bendamustine based therapy versus thalidomide based therapy for patients with renal dysfunction, NDMM patients with renal dysfunction. With that, I think we move on to our next event, that is the quiz, which is based on the General Club and the General Scan, which have been presented just now. So, Nirav, can you showcase the quiz questions, please? So as usual, we are going to have 5 questions for the quiz. The first question is, what is the RISS stage for this patient? A 54-year-old male. His ISS stage is 2. He has a normal LDH and he has no risk cytogenetics. So your time starts now. So is it RISS 1, 2, 3, or the information is inadequate for calculating RISS? Mind it, we are not asking R2 ISS, we are asking RISS. So in the current General Club, you have heard a lot about the first scoring system, prognostic classification, which came into practice in 1975. So which of these people are associated for bringing out the first prognostic classification? I won't tell you the names of these people because that makes your answer very easy. But out of the 4 photographs which are shown here, which of them is associated with the first prognostic classification, that is the Dury-Salmon classification? Yeah, you can go to the next slide, please. Next question. All the following are limitations of the R2ISS, which have been brought out both by Dr. Stalin and Dr. Vincent in the study which was presented today, except prognostication in newer regimens is precluded in the current study. Transplant eligible patients were less than the non-transplant eligible patients in the whole patient population which was represented. R2ISS is validated only in trial patients, and it helps in improving discriminating capability compared to RISS. So which of the following is not a limitation of the R2ISS? Next question. Okay, the general scan was based on bendamustine. So we have a very simple question about bendamustine. Bendamustine belongs to which of the following drug groups? Is it an alkylator, antineoplastic agent, nitrogen mustard, all of the above? Next question. Okay, so a patient was being given bendamustine and it led to extravasation. What would be your line of therapy? Option A, subcutaneous injection of sodium thiosulfate, to apply topical DMSO, to give warm compresses. Mind it, it's not cold compresses. I have written warm compresses. 4th, to give injection hyaluronidase. So which of the following is the treatment for bendamustine extravasation? Next slide, please. I think with this, we come to the end of the quiz questions. We'll give you the answers. In the meantime, I want the event management team to kindly compile the answers and give us the fastest finger first. So coming to the answers, the first one. So a patient with ISS2 with normal LDH and no high-risk cytogenetics get into RISS2. Next slide. Next slide, please. Can we have the next slide? A patient with actually high LDH or a high-risk cytogenetics actually go into RISS3. And for having RISS1, the patient has to be in ISS1. So RISS2 is particularly those patients who neither fits into RISS1 or RISS3. Nirav, can we have the slides back, please? Yeah. So which of these are associated with the first prognostic classification? So the answer is number 3. Number 1 is Dr. Nikhil Munshi. He happens to be the current president of the IMS. Number 2 is Bart Balogi. In fact, if people who have paid concentration, it's scripted here on his apron or a white coat. So he is famous for the total therapy in multiple myeloma. Number 3 is Brand Dury, GM Dury. So he's the one who was associated with the Dury-Salmon classification. And number 4 is Bob Kyle or Robert Kyle. The name to fame being about description about MGUS, smoldering, and for giving us the natural history of patients with myeloma. So the correct answer is number 3. Next slide, please. Next slide. So bendamustine belongs to which group? I think we had one question missed in between, the R2 ISS question, the number 3, question number 3. Previous slide. Yeah. So all of the following are limitations of the R2 ISS study presented today, except so R2 ISS definitely has an improved discriminating capability for the patients compared to the RISS, as has been shown or elucidated very well by Dr. Stalin in the graphs, wherein they can actually identify or discriminate the patients better into 4 groups. But the top 3 remains to be the limitations, which were enumerated by the slides in the limitation section of the presenter. Next slide. So bendamustine happens to be alkylator. It is also antineoplastic agent, and it's also a type of nitrogen mustard. So the answer happens to be all the above. Next slide. So bendamustine is an alkylator. Whenever we have extravasation with any of the drugs, so the steps which needs to be followed for all the students who are currently listening to the Journal Club: 1, stop infusion then and there itself. Don't try to pull out the cannula. Try to identify the amount of extravasation and aspirate out whatever possible. But don't try to squeeze out the hand to try to aspirate the thing. Take a pen, demarcate the area of extravasation. Thereafter, identify which group of the drug got extravasated. Take out the cannula. If they are vesicants, non-vesicants is the first classification. If it is a non-vesicant, just give cold compresses. No antidote needs to be given. If it is vesicant or irritant, there are 2 broad groups. If it is vinca alkaloid or one of those group of drugs, then you need to try to disseminate the drug. So you give hyaluronidase and you give warm compresses. But if it is a anthracycline, in that case, you give cold compresses. You try to give DMSO, topical DMSO, as one of the drugs, or any of the specific antidotes which are available for the group of drugs that are available. In case of bendamustine, you give sodium thiosulfate as an antidote for this group of drugs. So the answer happens to be subcutaneous injection of sodium thiosulfate. With this, we come to the end of the quiz and the answers for the quiz.
Sir, it is Dr. Dinesh from Madras Medical College.
Wonderful. So this is the second time that Madras Medical College is winning the quiz. So heartiest congratulations, Mr. Dinesh. And I will quickly wrap up the thing by showing you the last few slides about the next Journal Club. So can I have the permission to present my slides?
Yes, sir.
So next 4th Thursday happens to be 23rd of February, wherein we are going to have Dr. Nupur as our expert, international expert. It's going to be 5:30 p.m. sharp, Indian Standard Time. I would like to extend my gratitude to the Scientific or the Newsletter Committee, that is Dr. Das, Dr. Joseph John, and Dr. Hari Menon for this event, and our support to the other executive members. Special thanks to Dr. Vincent for sparing his time and early in the morning at Rochester during a winter January morning to come and share his expert comment. And sir, we are really thankful to you for your crisp and in-depth understanding of the trials and the way you explain us and answer the queries. So heartfelt gratitude to you for sparing your time. So with this, we come to the end of the meeting, and I would hand over the stage to Dr. Pankaj Malhotra, the president of Image, to give the concluding remarks and close the session.
Okay. Thank you. So first of all, thank you, Vincent, for joining early in the morning and continuing with the previous Journal Club, giving the overview of, when an article is published, why an article, why the study is done, and what is the rationale of that particular study. I think this message should go clearly to the residents and fellows that instead of just mugging up the study or impressed by the article which is published in a high ranking journal, the idea is to go into the details why a study is being done and what is the purpose and how can we apply that particular study in our day-to-day practice. So thank you so much, Vincent, and thank you, Dr. Das and Dr. Stalin and Dr. Sadashivdu for carrying out this Journal Club, and thanks to all the other people, especially to Dr. Uday for doing the Eagle Eye competition as well as the quiz. So with that, thank you very much for all the attendees who are listening to this Journal Club, and we hope to see you 4th Thursday of February, that means 23rd February, with the new journal article, which would be shared through the emails. Thank you very much and have a good day.
Thank you very much, sir. Thank you.
Thank you.